This talk is going to focus on screening tools for identifying people at risk for ACL injuries. And we're going to start with a prospective study done in 2005 by Hewitt's group in Ohio, where they looked at biomechanical measures that would identify people who are prone to this heart attack of the knee pattern, or this knee abduction dynamic, what they're calling dynamic valgus pattern, which shown in this picture, is attributable to both hip mechanics and foot mechanics, as well as abnormal knee motion. And so the bottom line is this study showed that the knee abduction moment was a predictor of prospectively predicted people that had ACL injuries. So they basically collected a large sample of subjects using motion analysis instrumentation, and then watched to see who would get injured and who would not. And the best predictor of who would get injured was the knee abduction moment, and its sensitivities, specificities were somewhere in the 80s. So not perfect. There was some, it didn't perfectly predict who got injured, but it was a substantial improvement over just classifying somebody based on gender. So as a result of this, people started to come up with other ways than motion analysis data, which takes too much time and effort to determine who was at risk. And so they started using video analysis, and here's a sequence of clips from the video analysis. One person, the superior view, is coming down from a box jump, and you can see they're landing with their knees maintained fairly far apart, and then going into another jump and then land. If we compare that to the female on the bottom, we can see that as the person comes down, their knees come together. As a matter of fact, they actually touch, and they come down, and then repeat that process. So the idea would be is that the person on the lower set of pictures, the female, has a knee abduction moment because her ground reaction force is passing lateral to the knee joint center, and therefore would be at risk for ACL injury. So, and this came out in 2010, same group from Ohio. This is their kind of classification of different things that should be targeted in terms of the relationship between mechanism, neuromuscular imbalance, and neuromuscular intervention for ACL injury prevention. In the female athlete, we can see her injury mechanism components, so things contributing to the injury, the neuromuscular reason for that, and then some of the things you might target in terms of your training. So if they have a knee adduction during landing, okay, which means that's their kinematic that you're looking at, not the moments, then they're loading their ligaments too much, and then you train for proper technique, which means they would adduct their knees more, so they'd put them in a more abducted position. So then lower knee flexion angle on landing, and so basically if they're keeping their knees straight, that means they're contracting their quadriceps too strongly, and essentially that could lead to an anterior drawer, which strains the ACL and leads to injury. Asymmetrical landings, what you're afraid of there is that the trunk may be leaning to the left or right, and a left or right trunk lean may be associated with a specific leg dominance, so the right or the left leg is more dependent on, and so therefore that that asymmetry may lead to a varus or valgus moment that results in an injury. So then you try to train towards symmetry, and then inability to control the center of mass. So again, here you're looking at now specifically at trunk position and trunk stability, and then if that's off, then you're going to work on core stability. So that's some kind of general categorizations to look at this kind of injury. So we can see here's the heart attack of the knee, and again, it's very similar to the movies that we saw earlier, the legs out, and essentially the knee falls inwardly. And so here's a study trying to validate an instrument where they're looking at the predictors of these different abnormal kinematics, and the thing they kinetics, so the things that the kinematic predictors or visual predictors you pull off of a video that best predict these kinematics are going to be the most valid, ideally in predicting injury. And so basically they looked at several different variables that you'd pull off of the visual assessment of the person's movement, things like knee valgus motion, knee flexion range of motion, body mass, tibia length. And they see which ones of those actually predict the knee abduction moment. So CAM here stands for knee abduction moment. And what they were suggesting is that these sensitivity specificities suggest that these variables were highly connected to the knee abduction moment, and we can see some of the data here. So what were they using? They were basically looking at just a high-speed video. So here's a Panasonic DV camcorder that's being used to look at the person's motion, and they're looking at how much the motion kind of correlates to motion collected in the biomechanics lab. And essentially the bottom line was it wasn't perfect because it's a 2D motion trying to predict a 3D a 2D camera trying to capture 3D motion, and essentially the correlations were good but not perfect, and that's kind of what you'd expect. But the bottom line was they're likely good enough to screen and classify people as at risk. And so here's some of the scoring sheet that they used. You can see the different variables there: tibia length, knee flexion range of motion, mass, quadriceps, and then the total points and how they graded them. And so here's some of their rankings. So you can see here that what they're paying attention to is these kind of width of the knees here, and how long they're kind of tracking how long the tibia is, what their landing position here. So essentially and then how much deep knee flexion they get into. And so these are kind of their four key variables they're tracking. All right, and so here's some of the ways they would rank them. Okay, so the knee and thigh motion. So basically, here's this is their tracking form. They give them before, at the middle, and after the end of their prevention program. But essentially, what they're trying to do is look at grading them. So the lower extremity valgus at landing. So one here, if you look at the picture, that's an example of somebody who would be a yes. So if they demonstrated that, they get a check mark. The thighs do not reach parallel to peak of the jump. So here you can notice that their thighs are not, they're below horizontal. Okay, and so that would give them a check mark. This would be a positive test. Thighs not equal side to side during flight. So here their thighs are uneven, and so that would be another check mark. And then the fourth, now we get down to the fourth one. Now you're focusing more on foot position. And so here the feet are too close together, and so the closeness of the feet will increase the ability of the trunk to become destabilized because your base of support's too low. And then 5, foot placement not parallel front to back. So here you can see that here the feet, one foot's in front of the other one, and so they're arguing that it should be more symmetrical. And foot contact timing not equal. So here you have on the landing on number 6, you have the right foot is going to land before the left. And so it means that there's a chance that there would be a single leg stand that might be less stable than having both foot at the same time. And so essentially these are your criteria that people would get graded on, and that's what they have used in this particular program. So that's some of the ways people are trying to grade or look at ranking people with screening people with ACL at-risk patients, which are basically people with high exposures, meaning they're playing a lot of sports and they're female.